Hello, this is Dr. Nancy Trimbley with your Healthcare Arsenal podcast. This podcast is designed for that person who knows there's a better way towards health and wellness. They just don't know what that better way is. And my hope for you is that with each passing episode, you get closer to being your own best expert. Today, we have Nate Kloosterman, physical therapist, doctor of physical therapy. He and I have known each other for a number of years, and I'm not exactly sure where I first heard Nate's name from, but I kind of got that he worked differently than a lot of physical therapists that I had been acquainted with. He works from a holistic standpoint, and I'm going to let him tell his own story because I just have to tell you, when I first went to his place, his practice, I was overwhelmed by the complexity of the equipment and his viewpoint of wellness and physical healing. So, hi Nate, how are you?
Hey, yeah. Hi, Nancy. Good morning. And
Good
yeah,
morning.
thank you for that kind introduction. And I'm glad you had a good experience. And I think I take it as a compliment that that you think that we're a little bit different or a little bit unusual. In fact, when we go to school, we are really not trained too much in running a business. So when I worked with people on that, they said, "Well, you need to call it the physio difference because you guys are different." And so
I like
yeah, so
that.
I think we did have some marketing campaigns that kind of talked about the physio difference. You know, probably as well as I do. Uh, you get pigeonholed, and they think, oh, all chiropractors operate the same way, and they must do the same thing. And I think the same is true of PT. And so we've tried to gently push back on the idea of we're all the same, we do everything the same, and I got to admit that a lot of the things that we do are things that I learned from mentors. I learned from other people. And so I oftentimes really can't claim that I've had an original thought. I've had a few, but,
I am the same way. I don't have an original thought.
yeah,
I just put it together a little differently.
I think that's what I do too. And a lot of it then resonates with like-minded PTs. So that's who we attract to work with us. But to define that is probably something we'll be talking about later on. But that difference, that physio difference, it comes in various different forms, and so that's exactly what we do is
Yeah.
something slightly different.
Let's um let's just dive into that. I don't know if our whole audience has had experience with physical therapy. I will tell you from like my perspective, sometimes with some people, some patients or friends, they're in a physical therapy situation, and I know what's going on with them, and kind of what they need, even though I'm not a physical therapist, and I'm like, oh dear God, that's exactly the wrong thing that you should be doing.
You know,
And you're not feeling better. Are you telling your therapist? Oh yeah, I'm telling them. So they're in this cookie cutter scenario. Outcome doesn't really matter. It's just like, oh, this is the cookie cutter scenario for your diagnosis, which is your label that probably a medical doctor gave you that really doesn't have a good grasp on physical medicine either. So let's really dive into that and what's going on there, and yeah, how are you different?
yeah, I love that introduction to even this part that we're diving into because I'll start with my first experience with my first patient when I was a student. I walk into this hospital system or big box system, and I see a gentleman on one of these neuro tables, these big wide tables, with a towel in his mouth while his therapist, soon to be my instructor, is cranking on his knee, his total knee, and he's sweating, and I think he might even been crying. And I was like, what did I get myself into? I'm like, what am I doing here? And I mean, that was over 20 years ago. So I guess we could say, that was old school. And certainly the greatest generation, the people that have come out of those years, um, are no pain, no gain. That's their mentality. They've lived through the Depression. They lived through World War II. Not so much the people coming into our office these days, but still that notion of no pain, no gain has a trailing presence. And so part of it is educating people that no, we're going to do things a little bit differently. And to your point, they're doing the exact wrong thing. They're doing McKinsey with stenosis clients. They're doing foam
Yeah.
press ups to close off that intervertebral
I
foramen. Why are we doing this? And this then goes back to what I was talking about earlier, where I'm not sure I've had an original thought, but when I see mentors break things down in a very logical way, I like to think that I'm very logical. I like to think that I'm artistic too. So there are times for creativity, but there's also times for randomized control trials. And so when we look at what works, I just tend to gravitate towards things that make sense to me in a logical way. I know that's kind of an obvious statement, but the methods then to dive just a little bit deeper that we use, and I'll just maybe stay in the world of exercise, because we do manual therapy. We do trigger point dry needling, which has been profoundly impactful. We do something called Pilates, which helps sort of stabilize and lengthen and tone the muscles simultaneously. And maybe we'll talk about Redcord, which is one of our unique value propositions in our business. But medical exercise therapy is a nice segue from what we'll call traditional therapy to what we do at PhysioPoint. And medical exercise therapy takes into account individualization principle. So that pushes back against your cookie cutter, problem that we get. So there's the individualization. There's the progression principle. Why are they doing 3 sets of 10 with a yellow TheraBand 6 weeks, 8 weeks into their therapy? Are we progressing them? There's also the SAID principle, and that's specific adaptation to imposed demand. Why are we, and I hear this all the time, where they went to therapy and they go, I have a back pain and he has a knee pain and she has a shoulder pain, and they're doing all the same exercises. Are we providing stimulus appropriate to what their impairment is? And so to even link impairment to what you were talking about, ICD-10 diagnoses are putting people in a box. We treat movement. And so we look at movement impairments. And I have some new therapists that like to go for pain, and they talk about, I was going for their pain. And McKinsey is nothing wrong with McKinsey, but it's a patient response model. Okay, I do this. How does that feel? I do this. How does that feel? And everything's based on how they feel versus maybe a biomechanical approach that would then say, okay, this is not moving well. This is moving well. Is it neurologic fatigue and weakness? Is it metabolic fatigue and weakness? And then can we match the impairment to whatever, or the treatment to whatever impairment we have, which then says,
Right.
who cares if it's a meniscus? Who cares if it's a disc? Who cares if it's what tissue it is? Not to say that,
Right.
right? Not to say that tissue
Right.
diagnosis is irrelevant, but I do believe that ICD-10 diagnosis misses the opportunity to look at movement impairments.
Yes. So just to kind of bring that into clear focus for our audience, and this is why Nate and I are like kindred spirits. This is
Mhm,
why when we first met, we were like, yeah, we
mhm.
we understand each other. In my book, Stealth Health, I write about the diagnosis and what a diagnosis is, and how the conventional medical model takes the signs and the symptoms of a patient and formulates a diagnosis and treats the
Yep,
diagnosis,
yep.
and how that's not individualization, that is not treating the individual and their different nuances. It's treating a diagnosis. That's why when I said earlier, the medical doctor makes a diagnosis and the therapist just is treating the diagnosis.
Mhm.
Another thing you bring up, which is really profound, is that, is it pain or is it function? And I think the general population kind of melds the two,
Mhm.
either thinking I have a pain and I need to just bust through it and work through it. I need
Yep.
to yeah, it's going to fuel my fire, where that might be okay and that you might be damaging tissue.
Yep.
Or they have a pain and I think I can't do anything. I've got to stop right now. I can't do anything.
Yep.
And it's up to somebody that has an objective viewpoint to know, is this, like, in my realm, is it a structural misalignment? Is it a nerve root impingement? Is there neurological compromise? Because then that's three different pathways I have to explore.
Yep.
And then, like you were talking about the McKenzie method. Now, just I've talked about this on some YouTube videos. I've never talked about it on the podcast to explain it to the audience. McKenzie method is something that's done for a lower back issue.
Mm-hmm.
And in my world, in my chiropractic world, with the techniques I do techniques to open the nerve canal of the lower back.
Mm-hmm.
And in order to do that, I have to take a person who's laying face down and I have to flex them because that
Mm-hmm.
opens the nerve canal.
Mm-hmm.
Now, the McKenzie method is excellent for people that maybe have tight spinal ligaments or some other structure. But if there is nerve root impingement,
Mm-hmm.
and what McKenzie does is it puts you into a back bend and it closes down the nerve canal. And
Mm-hmm.
it's just anatomy to me, like, why are you doing that? The
Yep.
person's getting worse. So that's what Nate and I are talking about with McKenzie. And that's why, like, I want to like shake some
Mm-hmm.
chiropractors or physical therapists. Like,
Yeah.
why?
Yeah.
Why?
Yeah.
So anyway, so yeah, so let's delve into that a little bit and how you are different from other physical therapists in that way. You're treating the individual. One,
Yeah.
you are progressing the person on an individual path. If they're not
Mm-hmm.
ready for strengthening, you don't do strengthening.
Yep.
If they're super strong already, then you're going to dive into more of that because it's not cookie cutter.
Yep.
And tell me how that looks like with a singular patient, like if you can even think of a patient you've had where they walked in the door and you were able to almost triage what was going on with them to help them.
See, Nancy, the reason why I love this conversation is because you're asking the right questions. Something, you know what? And again, there's no pride here. There's no judgment here, but it just sure seems like these are questions that um, maybe some practitioners don't even care to ask or don't even know to ask. So hopefully this podcast becomes educational for your listeners. But one of the things that I think I like about your question is, and I'll try to give you a vignette, but I'll build on the fact that especially with exercise, if we're in the realm of exercise, stage of healing is key. You cannot treat a tendinosis like you treat a tendonitis. You cannot treat somebody who just tripped over, the curb as you do with somebody with a 20-year-old chronic ankle instability. And so to know the stage of healing, and of course you can have acute on chronic presentation, if you can understand what's going on with the tissue, you can guess, and I'll say you can guess your best in terms of how you should dose the treatment. Now let me go a little bit deeper on that, and this maybe I can use a vignette for that if you'd like, but let's call it rotator cuff tendonitis of the external rotator, supraspinatus and maybe infraspinatus, and we're in the acute phase, let's say. So it is.
So for the audience, the acute phase means it's a new injury and
Yep.
there's inflammation,
Yep.
which is the body's way of healing and
Yep.
protecting the injured area. The inflammatory process breaks down the broken tissue so that it can then later build new tissue. So go ahead.
Yep. Yep. And so when you're going to exercise that muscle, which you probably need to do at some point, you need to dose it. Now, and again, Nancy's talked about some of her concerns with the way therapy is being done. This is one of my pet peeves, and that is that um, they choose numbers of 10 or 15, multiples of 10 or 15, or maybe 30, and it's randomized. But if you look at, and all of the listeners will know this, if you use heavy weight, are you going to do high or low repetitions? The answer is low. If you're going to do low weight, are you going to do high repetitions or low repetitions? And the answer is they're inversely proportional. And why that's important is if I'm going to start somebody with a tendonitis on an exercise, simply to say it didn't hurt them doesn't necessarily mean it's therapeutic. If you went to your physician and let's say you had diabetes and they handed you some insulin or metformin, and they said, here's 100 pills, take them, I don't know, let's just say, let's take 10 a day if you feel like it. And they never tested your blood, right? It'd be insane. They never
Right.
tested your blood sugar. They never said, well, you should use this much insulin for this blood sugar, this deficit in your blood sugar. And we never even analyzed it. If you don't test what you treat, Nancy, you're just shooting in the dark. And so
Yes.
what we do is we do what we call a clinical fatigue test, or basically it's a threshold test. So you do your exercise with a guess. And like I said, you have to guess the weight because you don't know what you're dealing with. And so you guess a particular weight, as many reps as you can do, stop if it increases your pain. Because if it increases your pain, we know it's probably not the right weight or not the right exercise. So you land on 17. Whoa, that's not a multiple of five. Oh my goodness, right? And we say, all right, with that particular arbitrary weight, maybe it was 2 pounds, you did 17 reps. Perfect. Now we know, we just took your blood sugar, right? We know
That's
what
right.
your
We have a
threshold of weight.
starting
So
point.
we know your starting point. Otherwise, we're guessing. And so that's where the individualization principle I talked about earlier comes in. Because if I look at, we had it before where we assumed wrong, right? And we said, okay, and you have to take into account stage of healing, maybe gender, maybe muscle size,
Sure.
age,
Age.
all of that stuff. Yep.
Mm-hmm.
And we've got it wrong before, where we went, oh, we didn't know this was a runner. We thought they were a cyclist, and so is in the was not developed the same way as somebody that's in pedals that's pulling. So all that to say, if you dose the exercise, and I would say this for even personal trainers, if they dose the exercise, not only are they going to prevent injury, but equally important, I believe, is they're going to give them the appropriate load, which is a good thing. Stress is a good thing as long as it's appropriate stress. And so when you stress the muscles and sometimes the joints appropriately, the outcome that you get is going to be far superior than if you're just randomly guessing and,
Mm-hmm.
oh, at least I didn't hurt them. And that's not always the case.
Right, right.
Mm-hmm.
So what you're doing is you're developing an individual starting point
Mm-hmm.
for this individual patient with this, they're in this stage of healing.
Mm-hmm.
They are this age, this gender. So let's figure out what's our starting point. And then you have something to measure back to as time goes on
Yep.
by being able to increase the weight from 2 pounds to 3 pounds, or increasing the reps from 17 to 20.
Yep.
Um,
Yep.
so in that regard, what's your patient feedback? Like, what do you hear from your patients, especially patients that have been to other physical therapists? How do they report to you, like what they feel the difference is?
Yeah. Yeah. Thank you for asking that question. And I'll take a kind of a twisty turn to answer it, but I don't know what's happened since COVID, but we have so many limitations from prior authorization from insurance to where I'm like, why are we getting 6 visits? Why are we only getting 8 visits? And so we do a high amount of insurance business. So at the end of the day, we're like, well, how can we be better? And we were well positioned for that because we've been dosing for years. But what happens is if you dose, then you're going to make sure that each and every visit is optimal. So if you're going to progress them from that 17 to 20 reps, like you mentioned, and you have to do that, okay, in 3 weeks we'll adjust them. You could do that and then dose them every 6 weeks. What we had to do is change. We had to adapt and overcome. We dose every visit. We say, okay, your first set of your 3 repetitions is dosing. We're going to take your blood sugar every visit. You know the analogy, not their blood sugar, but
The
their
analogy,
their,
right?
their threshold test, and we're going to do that every visit so that then the the quality or the intensity of each visit is optimized. And so what we're hearing back from them is that they don't know the behind the scenes that back in the olden days we got unlimited visits, but now they realize, okay, when I went to that other therapist, they really didn't do much for me. And part of it was because they were under the same pressure we were, which is get them better quicker. And sometimes that's a challenge, and you don't always have the tools to navigate that.
Right. And again, one of the things I talk about in stealth health is how the insurance industry is part of what I call the system that's been making us sick our whole lives.
Yeah.
Conventional medical model, pharmaceutical industry, chemical industries, food industries, and the insurance industry, and I don't know why, is wrapped up in that whole thing where
Mm-hmm.
they would rather, like in my world, for some patients, they would rather pay for an MRI,
Yeah.
they'd rather pay for steroid injections rather than pay for, and rather pay for a surgery even than pay for chiropractic care that would keep them from surgery.
Yeah. I don't understand it either. Yeah.
It makes no sense. And yeah, since COVID, I think the insurance industry lost so much money during COVID. They're trying to trying to make it back
Hmm.
by limiting more.
Yep.
Yeah, and it's the patient that suffers, and they don't understand.
Right.
They don't understand their insurance coverage, and I know you probably have heard this too. It's like, well, you billed it wrong. I'm like, there's only one way to bill. It's only one way. I can use about 5 different billing codes, and that's it.
Yeah, I know.
Yes, but you have overcome that just by strategizing
Hmm.
and fine tuning it, which, it's interesting. Another analogy between us, it's always been, but especially the last few years, my office and our tagline is we help the unhelpable. We want to get people better fast.
Yep.
It breaks my heart when people come in, they've seen another chiropractor, they were there for 3 months, and they're
Hmm.
like, "Yeah, I might have been a little bit better." I'm like, "Oh, no. Oh, no.
Yep.
You're gonna be different in a week or 2. That's my goal for you,
Yep.
is we're gonna get you back to work, we're gonna get you back to playing with your grandkids, whatever it is,
Hmm.
that's as fast as possible."
I love
So,
that.
yeah.
That's
Yeah,
awesome.
so you have been done the same, and patients love that. I call it
Hmm.
the convenience factor. They don't have to come see me ad
Yep.
nauseum. It's going to be, nope, we're going to make it convenient. We're going to get you back. So that's pretty cool. That's pretty
Yeah.
cool.
Yeah. Yeah.
Now, when somebody comes in to see you, and you get, the paperwork, you look at the paperwork, you talk to them about what their injury or issue is, and you talked about finding that starting point.
Hmm.
So what types of analysis do you do on a patient when they come in?
Yeah. That's a pretty complex question. And what I guess I would say to your audience is, the analogy. I'll go from a 50,000 foot view first, and the analogy I often share with my clients is that I wouldn't start pulling wires and tires before I know what's wrong with the car, right? That would be insanity. So I use that first visit and I set the stage to let them know we're going to do our best to get to the root of your problem during this session. And after that, you know, then it'll be treatments. But to be honest with you, we're always reassessing and evaluating. But
Right.
that first visit is an hour, and that seems like a long time. But we use dynamometric muscle testing, which then I had mentioned before, metabolic muscle weakness. So if the muscle just can't produce force and it's weak as normal people think of weakness, we can pick that up with a little gauge because we can measure it. We also
Hmm.
look for neurologic fatigue and weakness, probably similar to your work, where if they can't hold an isometric contraction for a period of time and it just gives out, we can trace that back to the nerve root. Okay. There's also the methods of FMS, which there's a brilliant guy named Gray Cook who classified things as either functional or dysfunctional, painful or non-painful. So we don't forget about pain. We had this discussion earlier, you and I, but we have to then put it in its, we have to use it for what it's worth. We also, of course, do the reflexes, myotomal testing, all of that stuff. But the big thing I think that maybe separates us is helping understand balances. So we do dry needling. So all of a sudden people start thinking
Oh,
about qi or yin and yang and Eastern medicine. Nothing against it. It's just we don't operate
yeah.
in
You
that.
don't do it.
We don't do that. We do dry needling. If a muscle's tight, we make it loose. If a muscle's loose, we make it tight. So the balancing, in fact, I think there's some therapists out east that call it body tuning or rebalancing is a big, like, I think they've coined that term, as many people do. But I love the idea of rebalancing. As you know, the biggest thing that we struggle with, and a lot of people like to use posture as a scapegoat, maybe, but it is a real problem, and that is that we call it the universal pattern of inhibition. Basically, you know, cranial vertebral extension, forward head posture, internal shoulder rotation, thoracic flexion, lumbar hyperlordosis, internal rotation of the hips, knees flex, overpronation. You
Right.
get this
So you have this
gravity pushing
forward
you,
head.
yeah,
Hmm.
pushing you into
Hmm.
the ground, right, from head to toe. What we like to do is look at that and reverse that. So now we want to have craniovertebral flexion with the deep neck flexors. We want to see the head, just the alignment that you I know you look at as well. But why is that happening? Is there a muscle that's too tight? Is there a muscle that's too loose? Just because it's weak doesn't mean that it's unstable or inhibited. But you're going to want to look at things from many different angles without confusing yourself. And we have a very like I said, I've stolen a lot of things from mentors over the years, and our exam sheet is just an amalgamation of different ways to pick up problems and do that detective work that a good mechanic or a good
That's and
yeah,
that's what it is. It's detective work.
yeah,
I like to call it a puzzle. I love what I do, and I probably will always do
yep,
my work as a chiropractor because it's just like this puzzle I get to
yep,
figure out. And like you said, people come in as they go through treatment. Every time they come in, they're a little different, and it's
hmm,
a little bit of a different puzzle, or the layers of the onion start shedding, and
totally,
things get better, and other things show up.
yes,
Tell the audience about dry needling. I've never had it done.
okay,
I've seen the results of it, and it definitely works.
yeah,
It sounds super scary,
I know,
but
yeah, yeah.
but it works. Tell the audience about that whole thing.
Yeah, it's kind of taken the world by storm, and I'll tell you, like I said, I look at the big movers and shakers in our profession, and then I just do what they do, and I learn from them. And all these guys were doing dry needling, and I was like, shenanigans! What is this Eastern medicine stuff? And like yin and yang, and gallbladder points. So I go, and I had hip pain for 20 years, and in courses, you got to be the subject, you got to be the pincushion for your partner just learned it 2 hours ago, and now he's
Right.
practicing, right?
That's
And
why as students we come out of school and we're all a mess.
yeah, so they were asking for volunteers for the front. I was like, oh, as soon as they get to the hip, I'm gonna be the volunteer. I don't want to show my rear end to 25 strangers, but on the other hand, like I want my hip pain gone. So I want the teacher doing my hip, not the guy who just learned it 2 hours ago. So I go up there, and essentially what happens is a fine filament needle or an acupuncture needle gets put into a trigger point, the Travell and Simon's trigger points. And what I believe happens, and there's some debate, we don't always know why things work, but what I believe happens is it resets the electrical activity of the muscle. So more often than not, muscles like piriform, well, back to that universal pattern of inhibition. When you're thoracically flexed, you're going to have pecs tight, you're going to have suboccipitals tight, okay? But the antagonists, the lower traps, are going to be inhibited. The beautiful thing about the dry needle is when it goes into the trigger point of either a tight muscle or a bright light bulb, or if it goes into a dim light bulb or a inhibited muscle, or we'll call it a loose muscle, it resets it. And that's that balancing I was talking about earlier, where if you reset that balance, either anterior to posterior or sometimes lateral and medial, then it helps the body move better. That's not going to be picked up in a medical exam or a medical physical, but that's something that's going to. And there's no ICD-9 to say universal pattern of inhibition, right? We know that, but that's what dry needling does, and it causes a little twitch contraction. And I do it with like 99% of my clients.
Wow.
I say, Nancy, are you afraid of needles? And if they're afraid of needles, they had a bad experience, and they say, yeah, I don't like needles. They are the only person, with the exception of people that are contraindicated, that I will not dry needle. But everybody else, the first time you do it, you're like, I'm going to put a needle into your muscle, and you're a little nervous about it. But I think I've been doing it 15 years or so. Now I'm like, here's what we're going to do, and this is going to make you better. And I don't even make a big deal about it. And it works.
And it works.
Yeah.
And it works the first time, right?
Well, that's the thing, is it is kind of for lack of a better term, it's kind of a sexy tool because it does make quick results, which people of course love, as you mentioned earlier. But the work, then, at least the way we believe it, is you got to do stuff afterwards. Even when you get
Ah,
people's joints moving, it's not like you send them out the door and say, okay, you have them use that joint through its new range of motion, so we can retrain the mechanoreceptors, the Golgi tendon, and all of a sudden now it
right.
sticks. It's what you guys say when you say, hey, it looks like your adjustment's stuck, right? Or I've heard that verbiage before, and
It's holding. It's holding.
holding, yeah, stuck, not
Mm-hmm.
stuck, holding, yeah, your
Right.
adjustment holding, yeah, exactly.
Yeah. I didn't realize you did that much. The word on the street
Yeah.
is if you need dry needling, go to Nate. I don't know if you know that.
Oh, I got some really good. I got some really good guys that are better than me now. So, but yeah,
Do
we
you,
love
you know,
it. Yeah.
yeah, I mean that's how we are too. And I when I I've got a doc that works with me now. She works when I'm not there, and yeah, I'm not holding anything back. Like here's all the secrets I have learned over the last 30 years distilled for you. You don't have to do this
Mhm.
path of discovery and trial and error. This is
Yeah.
what works,
Isn't that
and
fun?
this is the scenario that you use it in. And so then she is like on a fast ramp to success. And I'm sure your associates that you brought on
Mhm.
must be like thrilled to have all this knowledge that you have condensed over the years yourself.
Mhm. You know what? I'm going to interrupt. What it is, I was trying to coin a term for it, and maybe you can help me because I just haven't come up with it yet. But you've got craft brewers and you got, artisan bakers. And I just have this vision of like, where has medicine gone? You talked about that a little bit earlier. And the days of the blacksmith who takes a young lad or a young woman under his arm and says, "Hey, this is how you make horseshoes." Those days are gone. But I'm pushing back against that. I'm saying, hey, just like you, I've gathered a lot of information. A lot of it, I'll admit, has been assimilation, but I know what works. And it's not a randomized controlled trial telling me that. It's clinical experience. And
Hmm.
then to hold that, I mean, I'm a Christian, so like it's kind of like what's the little song, like hide your light under a bushel? No, I'm gonna let it shine. I just can't help but want to share the good the good news of how to do therapy in a different way. And that's what I get excited about, and it sounds like you do too.
Yes, yes, and I totally agree. I've had I think I've had 11 associates over the years, and I had a written manual, and they
Hmm.
would shadow me for weeks. And if they had a patient that was like confusing them, I would jump in and help them. Um, and they except for maybe one or two, they are all in their own successful practices now, and I am so thrilled that I was able to help them to spread the word of
Yeah.
chiropractic and holistic healing and healing from within. Um,
Kudos to you
and
for doing that.
yeah, hey, thanks.
Yeah, yeah.
And I wonder if one of the differences with you also is it's again analogous to chiropractic, where we from day one we talk about the art, science, and philosophy of chiropractic because
Hmm.
it's very science based. But like you say, I would trust more clinical response, like people in my that I see personally. I would trust
Hmm.
that more than a randomized trial that was done with 30 people in Canada.
Totally.
Um, and then it's an art because we have to draw upon like so many different pieces of information that we have learned as knowledge, but now when it becomes part of us, it is just it's our paintbrush, it's how we see things, and it's
Hmm.
that is where the artistry comes in. And for us, there's a philosophy that we know how healing comes from within. We
Hmm.
know that given the right circumstance, removing the obstructions or giving the body what it needs, the body will heal.
Yep.
And so it sounds like this is why, again, why you and I are so like kindred, because this is how we operate. Like we don't have to try. It's how we operate.
Yeah. I just hope it never gets lost, you know, with the world that we live in today. So,
Well, that's why I'm sitting here doing this podcast with you, because people need to know. My audience, they are clamoring for a better way,
hmm,
a better way towards health and healing, because they know that the big pharma route is not it. It's so far from being health and healing.
yeah,
And yeah, there's a time and place for conventional medicine and crisis care and pharmaceuticals. There's a time and place. But
absolutely.
for if more people saw, if more of the community saw people like you, like me,
Hmm.
like the naturopath I've interviewed, the homeopaths I've interviewed, the massage therapists I've interviewed,
Yeah,
if more people would do that, there we would cut the pharmaceutical use probably by three quarters.
yeah,
Um, the hospitals would be empty.
Yeah.
It is. So I think, I feel, Nate, like we're on a brink.
Hmm.
I've heard that 11% of the population uses some kind of holistic healing.
Oh, okay.
And I've also heard if we can just get a little bit more percentage points, that there's a tipping point, and all of a sudden that will be the norm.
Mm. Yeah.
So
I love that
that,
thought.
you know what, that brings up a question for me.
Yeah.
And then we'll wrap it up. But the question is, do people come see you for like wellness, or like, oh man, my golf game's off, doc. I don't want to go through my insurance. Just, can you just see me? Can you just help me
Yeah.
out with?
Yeah, we do a little bit of that, and I've got shiny object syndrome. So every once in a while, I'll be like, maybe we should do this, maybe we should do that. And right now, my shiny object is it's a golf rehab slash performance program. So the beauty in golf is you can play it well into your 80s and potentially 90s as long as you're healthy. And to be honest with you, the golf movement is not super great for the lumbar spine, but there's you talk about performance, that then gets into the world of kinesiology and understanding human movement, and so that's fun for us too. So we went through the TPI training, which is Titleist Performance Institute, and that allows us then, and Greg Cook and Greg Rose and some of these other guys. Greg Rose is a chiropractor, Greg Cook is a PT, but again, like you and I, very kindred spirits and how they think. And they then work with all the PGA professionals and everything like that. So they're doing the mentoring, the mentor mentee relationship thing across the board. They've monetized it well because they have Titleists backing them, and they're training all sorts of chiros and PTs on how to do this. And so we jumped on board with that, and so we do a little bit of that, Nancy. But for the most part, we try to. It's better if I stay in my lane of PT, but and that's where you're gifting in some of these. I don't know if you have shiny object syndrome too, but it looks like you've got lots of different ways to heal people, and I think I would love to learn more about what you do. That's not something we pretty much stay into our PT lane, but there's just so much out there. It's If you're like me, you're like, I want to do that, I want to learn that. There's just so much. You can't be good at everything,
I
that I
can't.
always have to remind myself, like, stay in my lane. But now
Yes, yeah.
I did want to jump in on one thing real quick, and we'll see if this theory comes true. But I have a theory that really piggybacks to what you were just talking about with the shift that we might see that you're predicting. I have a very similar prediction that it's not going to be somebody with MD behind their name or PT or DC behind their name that can revolutionize the problems that we're facing. I think with all the information age, all of this information available to us, people on their own health journeys are oftentimes figuring things out. When you think of like Lyme disease and all sorts of other wackadoodle stuff, that they're like, we know more than the doctor about it, and I'm like, yep, you do. And that doesn't scare me. Like, Dr. Google, go for it. Learn as much as you want. It's the information age. I don't say don't do that. I say, they don't teach us everything in PT school, and they certainly don't teach everything in medical school. And we might have reasons why that we could discuss on a different podcast. But the idea here is the layperson, I think, needs to be respected, because you add information to passion, and it's just like you and me. Information plus passion equals excellence. And I think we're going to have the layperson that's going to influence the space. Not doing brain surgery, but more on the prevention and wellness side.
Yeah.
Mm,
Becoming your own best expert. That's what I talk about in Stealth Health too. It's
there you
about
go.
unraveling your own mystery, because you are an individual and only you know you. And like you say, have the passion to want to get your life back, because this issue you're having is stopping you.
Exactly.
Oh, well said.
Awesome.
I love it.
All
Hey, I do have one more question. Well, maybe
right.
two. So my next question is, now some of our listeners are far from where you and I are in Northwest
Mm.
Indiana. If somebody wanted to find a physical therapist that kind of had your realm of thinking, what might they ask when they call up their local physical therapy practice?
Yeah, that's a great question. I get it all the time. And I think I have some framework, but it's not, there's some probably holes in it. I was talking about big box therapy before. There's nothing wrong with that, I won't say any names, but big box therapy, it's just the system does not support the therapy that can be done well. like ours does. Our system supports people that are like-minded. So if you find a private practice, you're probably in better shape than if you're with a hospital system or a big box place. It's just a system thing. They're not bad therapists in there. And it does draw them. If they have a certification from the APTA, OCS, or something along those lines, that's probably pretty good. And then on that dry needling note, if they've pursued dry needling, they're probably similar to us, where they want to advance themselves and figure out unique tools. And one of the things that what we see is the ability to look for where they've been trained by. And if you can get that information, Kineticore, MyoPain, Dr. Mazzo is pretty good, and those are the big ones. Intricate Art are all ones that when I hear people have been trained by them, I know they know their way around a dry needle if they've been trained by those companies.
Wonderful. Good. All right. Final question.
Got it.
And this is not one of the ones I previewed for you.
All right.
If you had a billboard for
Yeah.
all to see, what would it say?
Ooh, man, it would probably say, "Move better, feel better."
Mm-hmm.
Probably what
Yes.
it would say.
Yes. Excellent. Nate, it has been so fun and such a
Absolutely.
pleasure. Great way to start my day. And for our audience, I will put some of these things that Nate and I talked about in the show notes and his contact information. And as always, with each passing episode, I hope you get closer to being your own best expert. Bye for now.
Thank you, Nancy.